We'll now turn to our chair of the steering committee for the Healthcare Reform Study Group, Ralph Townsend, and Ralph will have some introductory remarks and introduce our speakers for the day. Ralph?
Good morning. Thank you very much, Juanetta, and welcome everyone today. I think as many of you know, we're talking today about something called an 1115 waiver. Section 1115 is a section of the statutes that govern Medicaid. They allow the Secretary of Health and Human Services to approve experimental or demonstration projects to promote the objectives of Medicaid. Such a demonstration project gives the states additional flexibility in order to demonstrate the effectiveness of a particular new approach. In January of 2018, after a considerable amount of work within the state by not only state agencies, but by many of the nonprofits involved with behavioral health, at the request of the legislature in SB 74, the state of Alaska did apply to the Center for Medicaid and Medicare Services for an 1115 waiver specifically for behavioral health services. And the intent of that waiver is to create a data-driven, integrated behavioral health system of care for Alaskans who are experiencing serious mental health disorders, serious emotional disturbances, substance abuse, substance use disorders, co-occurring substance use and disorder and mental illness, and at-risk families and children. So today we've generously had 3 representatives from the Alaska Division of Behavioral Health to review the status of the implementation of that 1115 waiver, what outcomes we've realized already, and how those findings may inform and reshape behavioral health delivery in Alaska. Our speakers today are Dorothy Bunti Reed. Bunti is a behavioral health specialist and social services program coordinator. She will address the children's services encompassed in the waiver. Tina Voelker-Ross is a PhD psychologist and serves as a mental health clinician 3 within DHSS. She will address the crisis services transformations included in the waiver. And Theresa Johnson, who is a health programmer 3 and serves as the clinical services supervisor for the State Opioid Authority. She will speak to the substance abuse disorder elements of the waiver. So we're very pleased to have these representatives. And with that, I think I'm to introduce Bunti first.
Thank you, Mr. Townsend. What a nice introduction. And you paved the way very well for what I'm going to be saying. My colleagues and I have divided our presentation into sort of our areas of expertise. And I am primarily at this point in time working with children and young people of transition age, which is 18 to 22. And I have 9 grantees with the state and over 30 agencies that I work with regularly. So we're going to talk about an overview of our services with the 1115 Medicaid waiver. Okay, Theresa, I'm going to hope that you can keep up with me here. Can I change the channel or
I can. I'm ready. You just let me know.
Okay.
Next slide. Yep.
Oh, next slide, please. Okay, this is specific to the 1115 Medicaid waiver services in our continuum of care. And as Mr. Townsend said, this has, well, we've actually been working on this for some time, but what this adds is services where certain federal Medicaid requirements are waived. It may change eligibility for Medicaid itself. It can change eligibility for services. It can change the place that the services are happening or the type of provider that does the services. So basically, when they talk about a waiver, it's a very wide subject and they can waive all sorts of things. In our state, we still have state plan services, and state plan services are those that are traditional. And those can be anybody, and they're paid for by most insurances, not just Medicaid. Those are things like therapies, group therapy, individual therapy, marriage counseling, all of those kinds of therapies, family therapy. Those are the kind of things that any insurance pays for. Our 1115 Medicaid waiver waives eligibility requirements in most cases, and that's how we get those services. We also at the state of Alaska have grants, contracts, and provider agreements to have funding mechanisms for other needed services. Basically, in Alaska, we're making up for the high cost of doing business here with those grants, and they help with infrastructure or uncovered services that agencies need to stay alive. Next slide, please. The target populations of this particular 1115 waiver are three: children, adolescents, and their parents or caretakers with or at risk of mental health and substance abuse disorders, individuals with acute mental health needs, and individuals with substance use disorders. Now, one of the big changes is we really didn't have a robust substance abuse treatment prior to the waiver. The acute mental health needs, my colleague will be talking about the crisis services that have been put forward. And children and adolescents, we've always had some services for, but we're talking about their parents or caretakers with or at risk of, and this is the prevention component. We hope to get help to families before their problems become an emergency for everyone. Next slide, please. Okay, our behavioral health Medicaid is administered through the Division of Behavioral Health, and we traditionally serve the most acutely disabled children and youth, and that is defined as severely emotionally disturbed, and the most seriously mentally ill adults, defined as SMA adults, and covers both clinics and more intense services, including residential. Services must be medically necessary, clinically appropriate, and delivered by eligible providers. Care is delivered by community behavioral health centers, substance abuse treatment agencies, federally qualified health centers, tribal health organizations, hospitals, and specialty clinics. Go ahead. Okay, we started in 2016 with the passage of SB 74, as Mr. Townsend mentioned. The main goals of the reform effort were to improve effectiveness, efficiency, and integration of our behavioral health system. We hoped to reduce operational barriers and minimize administrative burdens. We hoped to expand the capacity for community-based mental health and substance use disorder treatment and community supports, support early intervention, support peer and family-based support services and interventions, and waive the IMD exclusion rule. Next slide, please. We established 5 goals to achieve the vision. One was expansion of treatment capacity and improved access to services, including prevention, home-based treatment, treatment foster care, SUD services for adolescents. Integration of care. We wanted to increase the capacity so that providers can provide or facilitate both behavioral health and substance abuse treatment. We wanted to do cost and outcomes reform. How do we know what we're doing is working? Provider payment and accountability reform. We contracted with a service organization called Optum, who will be handling, assuring that the level of care is met so that we can get paid for this. And delivery system report. We discontinued some service, we added new services, and we started to require evidence-based models. Next slide. This graph, and I hope that it's easily read, this is kind of an overview for children. And what you look at is in the gold color, those are the regular Medicaid services or regular insurance services, things like behavioral health screens, assessments, psychotherapy, some peer support services, medication and administration, and psychiatric residential treatment facilities. Then on our waiver, we added intensive case management, community recovery support services, intensive outpatient, partial hospitalization, home-based treatment levels 1, 2, and 3, therapeutic treatment homes, which was formerly called foster care, child residential treatment 1, and child residential treatment 2. Those are what we added. And then the 1115 crisis services are in orange, and my colleague will be speaking to that later. Next slide, please. Here are the children's 1115 substance misuse services, and none of them existed prior to the waiver. And that is under the 1115, there's intensive case management, substance abuse disorder care coordination, community recovery support, outpatient, ambulatory, intensive outpatient, and partial hospitalization. And then over on the right, it shows clinical managed residential and the other levels of residential for children's, the 1115 waiver substance use services. Next slide, please. Okay, here are the out-of-home services that exist in Alaska. And the first two are named in the waiver. The third is part of regular Medicaid. So that is therapeutic treatment homes. These are specially trained foster homes that take kids who they're severely emotionally disturbed, they experience difficulties in many life domains, but they're not serious enough to go into residential treatment. Children's residential treatment is a step up from those therapeutic treatment homes. It is a place where children can get therapies, skill development, and hopefully recover from the highest level of their illness. And then a residential psychiatric treatment facilities are lockdown facilities. This is a hospital level with psychiatrists observing. And I think what a lot of people think of when they think of inpatient hospital. And this is our continuum. And before the therapeutic treatment home on the left, we now have the home-based. And then on the residential treatment facility, if you were to take that arrow and go to the right, you would be seeing acute facilities. And that's what's on the bottom there. Next slide, please. Okay, therapeutic treatment homes. Statewide, we have 222 homes and 485 beds. We have one in Nome. Fairbanks has 19. And South Central and Kenai have a whole bunch. They have different agencies. Denali Family Services has 57, AK Child and Family 44, Hope 14, Family Centered Services, Kenai Peninsula Counseling, Presbyterian Hospitality House, and the Ark of Anchorage. And in the Southeast, we have about 35 of these therapeutic treatment homes. One of the very different things about this therapeutic treatment home is these are specialized foster homes. They're not licensed by the state's licensing authority, which licenses other residential facilities. These are licensed in partnership between the agency and when I say the agency, the nonprofit agency that is providing the service, and the Office of Children's Services. It's a dual licensing. Next slide, please. Okay, they are agency supervised private family home. They're medically necessary treatment and care for children or youth with significant emotional or behavioral problems. And what the medically necessary means is actually defined in the waiver. Parents have specialized training to provide individualized structured services. Some parents specialize in one area. Homes are managed by behavioral health agencies, overseeing and implementing evidence-based programs. And under the waiver, and this is a big change, is every individual providing services must be deemed eligible to bill. So it requires a level of knowledge that is above what we used to require. And referrals can come from OCS, DJJ, or the children's family. And most of our referrals come from OCS or DJJ at this time for those therapeutic treatment homes. Next slide, please. Okay, here is children's residential treatment. This did exist in a different form prior to the waiver. It was formerly called Behavioral Rehabilitative Services. And we have them statewide, Nome Community Center, Manilic Association, and North Slope in Northern. Fairbanks, right now, you used to have more, but now you just have family-centered services. Southwest, Yukon Kuskokwim Health Corporation and McCann Treatment Center. In the Southeast, we have Juneau Youth Services, Residential Youth Care, and Youth Advocates of Sitka. And through the South Central and Kenai, we have AK Child and Family, AK Baptist Family Services, which is rebranded as Birchwood, Providence Health and Services, Presbyterian Hospitality House, and Kenai Peninsula Community Care Center. Some of the children's residential specialize in certain things. We have one that specializes in adjudicated juvenile sex offenders, and we have one that specializes in children who are duly diagnosed with the intellectual disorder as well as a behavioral health disorder. Next slide, please. Okay, they are to treat psychosocial, emotional, and behavioral disorders. We have 2 service levels to address a range of symptoms and behaviors. We have level 1, which is assessment and stabilization and treatment that doesn't need medical personnel, which basically means that we don't need a psychiatrist on site. And level 2, residential treatment with medical supervision. Always includes the family, post-discharge placement unless clinically inappropriate. And the types of services offered are case management, therapeutic behavioral health care, skills development, support, and med administration. Next slide, please. Okay, the next I'm mentioning are the psychiatric residential treatment facilities. And in my capacity at the division, I don't deal a lot with the psychiatric residential treatment facilities, but we do have a whole lot of them that we use both in-state and out-state. In our in-state capacity is only 120 beds. And they're in South Central Anchorage and Palmer. They're all in the bowl. AK Child and Family, Providence Health Services, Alpine Academy, which is North Star, and Summit, which is North Star. Two parts of the same agency. And the latest records I have for right now are FY20, and there were 21 out-of-state facilities used, and that's throughout the lower 48. We're still sending kids out, although not at the level that we were before we started the Bring the Kids Home initiative. Next slide, please. Okay, the residential treatment facilities, or RPTFs, they serve the most serious kids. They usually have destructive or assaultive behaviors. They've identified as having intense needs. They need a truly structured setting with psychiatric services. And these are campus-based long-term, and there's a federal definition that they must meet. Next slide. Okay, acute care. All hospitals in the state of Alaska provide acute care as they can. But here are the ones who identify, and that is Fairbanks Memorial Hospital, North Star Behavioral Health, Providence Health, the Alaska Psychiatric Institute. In Southeast, it's Bartlett Regional Hospital, and actually Ketchikan General also provides those services. Usually these are, next slide, please. Usually acute services are quick services. Kids are stabilized and placed as soon as possible in a more appropriate environment. And the length of care is, it says 0 to 30 days, but we try really hard not to leave a kid in the hospital for 30 days, or actually anyone in the hospital for 30 days if we can get them to a more appropriate placement. Next slide. Okay, kids behavioral health waiver levels of care. For the waiver, we have home-based family treatment. I mentioned that before. There are levels 1, 2, and 3. Therapeutic treatment home, CRT1 and CRT2 are 2 residential. The outpatient state plan services and children's emergency services program. Next slide, please. The Children's Emergency Services Program was built out of something we identified when we were putting the waiver together, is that we had a blended population in some of our residential facilities prior to the waiver, where if a child was deemed in an emergency situation, they could be pulled into a youth home. And we had several youth homes in the state that both provided mental health services and provided a safe spot for emergency services for the kids. And when we looked at what the feds defined as levels of care, there's no diagnoses with these children. It may be that the family is in crisis. It may be parental incarceration. There are many reasons that a child could be pulled from their house and put in one of these emergency services program or one of these agencies. So we realized that we still needed stabilization and assessment programs for kids who were traumatized. They were in fact in need of these services, but they really didn't have a diagnosis at this time. So we created the Children's Emergency Services Program, which are provider agreements with certain agencies so that they can stabilize the child, work on life skills remediation, and work on a future placement if the child has therapeutic needs. This is short-term, and what we do is we cover the shelter costs for each child, and they're non-Medicaid reimbursable. These aren't medical services. These are just stabilizing the child, getting them safe, and then forwarding them to the level of help they need. Next slide, please. State plan services, again, are behavioral health screens, behavioral health assessments and psychotherapy, peer support services, med administration, and short-term crisis and stabilization. Next slide, please. I believe I'm done. I think the crisis response services will be my colleague, Tina.
Okay, so go ahead. Next slide, please, Theresa. So the 1115 crisis response services, as you can see, there's 4 of them. They're listed under the acute intervention services. Next slide. This originally, the state plan had only 2 services identified for crisis response services: short-term crisis intervention services and short-term crisis stabilization services. With the 1115 waiver services, we were able to expand those crisis response services to include peer-based crisis services, mobile outreach and crisis response services, 23-hour crisis observation and stabilization, and then crisis residential and stabilization services. Next slide, please. And the division has utilized SAMHSA national guidelines for behavioral health crisis care to guide our work in developing crisis services. The guidelines focus on 3 key areas, and that is making sure individuals who are in crisis have someone to talk to, someone to respond, and a place to go. Next slide, please. And you'll recognize those SAMHSA guidelines in the Crisis Now model, which is being implemented and developed by the Mental Health Trust. So those 1115 waiver services, as you see, can fit within those categories of someone to respond and a place to go. Next slide, please. So peer-based services. Utilization of peers is currently an emphasis in evidence-based practices in behavioral health. And it is when an individual uses their own lived experience to support and guide others who are struggling with similar experiences. It's considered a best practice by SAMHSA, and research shows that peers improve outcomes. Peer support services have been shown to reduce symptoms of crisis, mental health, substance use disorder issues, has been shown to reduce hospitalizations, increase social support and participation in the community, decrease lengths of hospital stays and costs of services, improve well-being, self-esteem, and social functioning, and encourage more thorough and longer lasting recoveries in individuals who are struggling with behavioral health issues. So it's really a very important component of crisis response services. And what the service includes is peers providing triage of crisis situations, determining the needs of persons in crisis, providing support, access to community resources, and referrals and advocacy. Becoming a support specialist, a peer support specialist, does require a state certification, and DBH currently uses grant funds to provide training, to support training statewide. And Alaska Behavioral Health is a primary training support for peer support services. And we currently have 77 certified peer support statewide. Next slide, please. The second service, mobile outreach and crisis response services. This would occur, say, if a person calls a crisis line, the police or 911, or in July, it will be 988. And a team is then dispatched out to the community to meet them where they are at. The team may consist of a professional as well as a peer support. They provide triage, assessment, de-escalate the individual, and provide support and referrals. And mobile outreach crisis services are provided 24/7. It's delivered anywhere in the community where the provider and the individual in crisis can maintain safety. And following the intervention, the mobile crisis team is required to follow up with the individual within 48 hours to ensure the stabilization and safety, as well as linkage to any referrals. Currently, we have teams in Anchorage and Fairbanks, and they're producing great outcomes. For example, in Anchorage, the mobile crisis team is implemented through the fire department. And from July 2021 to March 31st, 2022, they responded to 652 crisis callouts, with 369 unique individuals served. And with their intervention, 77% of the individuals remained in the community post-intervention. They also provided 461 follow-ups. And Fairbanks is also producing similar outcomes with a higher percentage of crises taken care of in the community. Next slide, please. There are two types of crisis stabilization facilities, 23-hour crisis observation and stabilization. And in 23-hour crisis stabilization, the services are provided 24/7. It's considered a no wrong door option, meaning that the 23 Crisis Observation Center accepts almost all individuals who are presented to them, such as police drop-offs, first responder drop-offs, walk-ins, really anyone who is in need of, who is in crisis and in need of services. It provides a safe, protected environment for up to 23 hours and 59 minutes where they can be observed, assessed, and the situation can be de-escalated. They stabilize the crisis and then determine the appropriate level of care and provide referrals if needed. In 23-hour crisis residential, it too is a 24/7 service. It's a safe home-like environment for, and it is short-term, again, focused on crisis stabilization. And they are able to provide their crisis intervention, stabilization, and community referrals. Next slide, please. Well, all of the crisis services we recommend they follow the SAMHSA best practices for crisis stabilization care, which includes addressing both mental health and recovery issues, utilizing peer supports and having a significant role for peer supports in the implementation of services, integration of trauma-informed care and zero suicide safer care, and then partnerships with first responders, including law enforcement and dispatch and EMS personnel. Next slide, please. In terms of 23-hour crisis residential and 23-hour and crisis residential 1115 waiver services, we're still really in early phase development of these services. We currently have a solicitation for 23-hour and crisis residential services with some dedicated funding for youth providers. And we have 14 agencies who are expressing an interest and have our approval to provide these services and are in that sort of developmental phase of moving forward. And DBH plans to provide technical assistance to those who are interested in FY23 so that we can move those services forward with some funding specifically towards training with youth. And I'm going to pass it over to Theresa now for substance use disorder services.
Sina.
Theresa, I'm sorry, I accidentally muted you. If you could unmute.
There I am. So I'm just going to start off with identifying individuals with substance use disorders as that third target population that was identified for services under the 1115 demonstration waiver. So Section 1115 demonstration waiver was implemented with the goal of transforming behavioral health system of care. Under this substance use disorder portion, the state has been able to do a few things. You know, they've been able to strengthen the continuum of care for substance use disorders by implementing the American Society of Addiction Medicine criteria, which has allowed providers to match patients with the appropriate level of care. We've been able to increase substance use disorder treatment options across the state, which has included alternatives to residential and inpatient services, just allowing a broader spectrum of services for people who are not appropriate for inpatient or residential substance use disorder treatment, increasing community-based support services, and expanding access to pharmacotherapies or medications for addiction treatment. So I'll sit a little bit with ASAM for just to give general information. So ASAM criteria is the most widely used comprehensive set of guidelines for treatment placement, continued stay in treatment, and transfer and discharge criteria for patients from treatment, patients with substance use and co-occurring disorders. So the ability of including the ASAM criteria, it has allowed providers in the state to align services so that we can address the specific needs for the individuals along the continuum of care. And this has also helped to standardize that quality of care and services that are received across the state. A little more about ASAM criteria. I promise you, I like to talk about it, but I promise this is the last slide. So ASAM utilizes 6 dimensions when assessing an individual's needs. So we're looking at a person's intoxication or withdrawal potential, a person's biomedical conditions or any complications they may have, a person's individual behavior or cognitive conditions, a person's readiness to change, a person's relapse potential, and their recovery environment. So those 6 dimensions are used to help a provider determine if a person, where a person falls on this level of care. You know, is Theresa in need of an early intervention? Does Theresa need referral to an outpatient service, or does she need residential treatment? And then the levels of clinical care. Again, this, I guess, diagram, this infographic here just kind of outlines, it tells what the criteria is for outpatient, for intensive outpatient and partial hospitalization, for level 3, which is clinically managed, and then for level 4, medically managed. And this will come together on this next infographic that you'll see. So this takes us right back to the graphic that Tina presented. And if you look closely, it's in alignment with that graphic that Bunti shared with the substance use disorder services for children or for youth, because this is the substance use disorder continuum of care for individuals 12 years and older. The orange services on here are the services that are available under the Medicaid state plan. And if you look at the blue, these are what are now available under the 1115 waiver. So, you know, when we speak to expansion, this visual really helps to see that there's a wider range of services that are now available, especially the ones that are in alignment with the ASAM criteria. And again, it's just better suited to address those specific needs that people have when they're receiving treatment. For a long time, the prevailing belief was a person has substance use disorder, they need to go to inpatient or residential treatment. Under the 1115 waiver, the continuum of care along outpatient services has expanded. So, for example, intensive outpatient programs have increased across the state. This matters because if Theresa is in need of some intervention or some assistance for substance use, I may have obligations at home, I may be raising a family, I may have a job. And so it wouldn't be appropriate for me and my condition. I don't have any medical conditions or any behavioral complications or cognitive complications. So residential or inpatient would not be appropriate, but there would be several options available for me to receive treatment and remain in the community and keep family intact or employment or whatever that specific situation is available to me. And so that's one of the pluses, expanding these outpatient services under the 1115. And so I'll back it up. What I'm going to do is just go through what these are. So the early intervention engagement services, really it's like preventive screening assessment, prevention and engagement. So a person, we need to know whether a person needs services. So under 1115, screenings are being done in medical settings for people to determine whether they have any behavioral health symptoms, children and adults. Once it's determined that there's some symptoms may be present, they can be addressed and an assessment can be conducted, and that assessment will be used to refer a person to the most appropriate level of care. And in this screening, it may also be determined that there is not a treatment need right now, but there is a need for some of those early intervention services. And so that is also how we know where a person lies on this continuum and how to get these services to them before it becomes an issue or a concern that would require treatment on some level. Next is community recovery support services. So this category is kind of just what it says, services that are available in the community to support people who are in recovery. Employment, recovery, you can read through those, but this is where we can provide those wraparound support services for people who are in recovery. So if a person has been to an inpatient level of care and they're returning to a community and they just need that wraparound support to increase their stability, that's what these services are for. If a person has completed that screening and it's been determined that they need a little support, but they're not quite ready for outpatient level treatment or inpatient, they can also use these services. And people who are involved in treatment in the community and need that support while they're carrying on their everyday engagement and everyday life can also use this. So community recovery support services are available for everyone along that continuum, just based on what they need and where they fit in. Next slide, I was going to take this opportunity. I know Tina spoke to peer support. Peer support is really exciting. These services are expanded under 1115 SUD waiver, and there are ongoing trainings right now in that certification process that Tina spoke to, but it's very important. And I say this after having been a provider for about 16 years in the community. Peer support services are really important. It's important for a person and it allows them to see that there is hope for them. No matter how dark the times got or how challenging it got, there is a person with the same lived experience or a similar lived experience, and they're able to be here to kind of show me what it looks like on the other side and give me that hope. So peer support services are really important, and they're being used across the continuum of care to support people in their journey along the way while they're in treatment, in recovery for ongoing support. So this is where I'll speak to outpatient services. So people may have heard of regular outpatient, intensive outpatient. We're speaking of services that a person is utilizing within the community. And under the ASAM criteria, we have ASAM level 1 and level 2 withdrawal management services. So withdrawal management is offered as inpatient and outpatient. And I'm gonna speak to the outpatient here because I mentioned earlier, not everybody is appropriate for inpatient or residential care. So even if you require withdrawal management, which just means I need some help with managing the withdrawal symptoms that I'm experiencing right now, a person can receive that in an outpatient setting. Ambulatory just means they can come and go in this program. And sometimes if I go to this program and I need a little more support, we have this ability to step up that treatment. So ASAM 2.1 is a more intensive outpatient program. And then partial hospitalization is again another step up, because what we want to do is identify that people can move along this continuum. They can step up or they can step down. If Theresa enters an ASAM 2.1 intensive outpatient program, and I'm just not successful, it's not helping me, I will get assessed, and that clinician can decide, hey, you know what, we need to step Theresa up into a residential level of care. Or Theresa's doing really well, and let's step her down into an ASAM 1 withdrawal management level of care, and then, you know, let her be successful within the community. So this expansion of outpatient services along this continuum under 1115 has just proved to be really helpful in allowing people to get what it is that they need at the appropriate level. Down here is opioid treatment programs and office-based opioid treatment programs. And I add them kind of because this is my wheelhouse. As a SOTA, I do a lot of explaining these things. But I want to make the point of differentiating office-based opioid treatment. You may hear it as an OBOT. It's in an outpatient physician setting. So down here, you may have heard the term buprenorphine prescriber, data waiver, X-waiver prescribers. This is the same kind of service that we're talking about. This is where we have providers who can prescribe buprenorphine for the treatment of opioid use disorder in an outpatient setting. Typically, they'll write a prescription, and a patient can take this to a pharmacy and get this medication filled, but they're receiving these withdrawal management services on an outpatient basis. Opioid treatment services, which are along that continuum of care, also include opioid treatment programs. And I just put down here because it occurred to me, they're formerly called methadone treatment centers, narcotic treatment centers. They're exactly the same thing, newer versions basically of the same word. Medications dispensed on site in these facilities. So these facilities actually have the 3 FDA approved medications available to be dispensed in these facilities for patients. It's methadone, buprenorphine, and naltrexone. The methadone option here I want to point out, because this is one way, the only way that a person can receive methadone for the treatment of opioid use disorder outside of a hospital setting. So in the community, this methadone would be dispensed to a patient inside of this facility. All the medication would be dispensed. And these programs, each of these programs are regulated. You know, OTP's federal regulation, their state requirements, they have DEA oversight. 42 CFR Part 8 guides them. And when we're talking about office-based treatment, again, because you're talking about licensed practitioners, they do have DEA certification and med board guides, medical board guides, the work that they do. So residential and inpatient treatment. Again, we're talking about withdrawal management. I pointed out earlier that it can happen in an outpatient setting or an inpatient setting. And I like to just bring the word detoxification in here because some people have also heard of detox. I went away to a detox program, which would be a residential or inpatient setting where they were able to manage their withdrawal, in addition to receiving any other support that they need. Because if we refer back to the diagram I had with that ASAM, and when I discussed those 6 dimensions, a person may have some medical issue, biomedical issues, some cognitive issues, whatever it may be, and they would be able to fit into the treatment level that they need under the improved or expanded residential and inpatient services under the 1115 waiver. So Again, there's been an increase in the different residential treatment levels. And when I say residential level, step up, step down, I mentioned earlier, if I'm in this 3.5 residential program and I'm doing pretty well and I'm meeting the criteria, but I'm not quite ready to be back out in the community, I can step down into a 3.1, which is less intense, but it still meets my needs. I want to point out that ASAM level 3.3 is a population-specific residential or inpatient program. And so under the 1115 waiver, we've been able to stand up 2 of these facilities in the state. One is in Fairbanks and one is at Central Penn, and it serves the Kenai and Soldotna areas. ASAM 3.3 residential treatment addresses the need for services for people with intellectual disability, cognitive impairments, or traumatic brain injuries. And this treatment is available and it is staffed by people who have experience working with this specific population so that they can bring them this information that they need, that in a supportive way, that they can learn it and be successful in their recovery. And so Bunti mentioned this as well on her infographic, and it was listed, and I want to kind of go into what the substance use care coordination is. It's very common for people to be receiving behavioral health treatment and receive primary health care services for any particular reason. So when we're thinking about people who may be receiving medication for addiction treatment, that's common as well. You know, they may have some medical issues and they have a regular primary care provider. They may also be working with a psychiatrist because they have some other identified issues. And this substance use care coordination allows for providers to receive reimbursement for being able to work together, collaborate. What we're trying to do is integrate these services for patients so that all of these providers know what's going on with the patient, which is really important when we're looking at healthcare. You know, substance use disorder treatment is healthcare when we're looking at this from a holistic standpoint. That is all I have. Again, this presentation was brought on by Bunti Reed, Children's Services, Tina Voelker-Ross, Crisis Services, and myself, Theresa Johnson, for substance use disorder. So thank you for having us this morning, and I will stop now, and I guess we can take questions if you have any.
Great. Thank you so much, Theresa and Bunti and Tina as well. We will be taking questions, and actually if Theresa, Tina, and Bunti, if you could turn on your cameras, I'll bring you all in on Spotlight so folks can focus on you. And let's see. Sorry, this takes me just 1 second. And Bunti, if you can turn on your camera when you get a chance, there you go. And let me turn to Ralph Townsend. Well, actually, let me do one thing first before I bring Ralph in. We've had a couple of clarifying questions in chat, and folks have been providing information, so we appreciate that. There was an early question on what is the IMD exclusion rule, and Farina Brown, also with the Division of Behavioral Health, is online with us, and she provided a written explanation about what that exclusion is and how the waiver helps to alleviate that exclusion. I don't know if either one of you want to provide any additional information on the IMD exclusion.
No, I think Farina did a great job.
Okay, great. And then there was also a question, how is medically necessary defined when with regard to substance use disorders, from Anna Nelson?
How is medically necessary? I'm sorry, repeat the question.
How is medically necessary defined when it comes to substance use disorders?
It would be defined by their a person's diagnosis. So a person is going to be assessed. They're going to receive a diagnosis, and we're also going back to that ASAM criteria that I spoke to. We're going to look at those 6 dimensions, and when I brought up that visual and it showed you which level is a person most appropriate for. So if utilizing that ASAM criteria, a person has, you know, a recovery environment where they need some support, or whichever of those 6 dimensions I spoke to, that's where we would get the information necessary to place them in the most appropriate level of care. But a person would also have a substance use disorder diagnosis, which again would be based off of an assessment that was completed by a provider.
Okay. All right, thank you for that. I'm going to bring Ralph in now. And Ralph, did you have any initial questions you'd like to pose to the?
Yeah, sure. The the 1115 waiver allows DHSS to provide an additional scope of services as part of a demonstration project. And I want to get back to that demonstration piece and ask, well, just a mechanical question, and that is, I believe the waiver expires at the end of 2023. And so a mechanical question is, are there plans in place to extend the waiver beyond 2023? And I also think that the report in 2023, or at the time of 2023, a report is required. And one of the issues in that report is the issue of budget neutrality that's normally required under the 1115 waivers. How the integration of these additional services impacts the broader view of beyond providing additional services. What are we trying to show CMS in terms of what we achieve with this?
So I think there were maybe a few questions. Yes, we're working on extension right now, and it would be a 2-year extension. And as it stands, we're on track so far to meet budget neutrality. And then where the last thing that you were asking?
Well, I mean, what the nature of demonstration projects are, we're trying to demonstrate to CMS the ability to deliver presumably both better quality services and with budget neutrality. And I guess my question is, where are we in terms of, with the extension, will the final report be due at the end of the extension, or will there be a report due at the end of 2023 with the initial waiver?
That's a good question.
Well, I know waivers require, I mean, I had looked at the waiver in preparation for this and seen that a report was required at the end of it. And I'm kind of curious if we're thinking about what it is we hope to show CMS.
As far as reporting?
Well, I mean, the report is, of course, writing up what's often a difficult thing to show, but we have in our heads what it is we're trying to show them, I think, when we say, what we're trying to do.
Right, so we do have a midpoint and an annual report that will be provided to them. Is that where you're asking, are we providing it to them at the end of the waiver? Yeah.
Well,
So,
yeah, what are the steps what are we trying to demonstrate? We're obviously expanded services, obviously, but it's more than expanded services. What are we trying to show CMS with this waiver?
so what we're trying to show is an increase in access to the mid and moderate levels of care and of treatment, and just aiming to reduce that inpatient and residential levels of care. So the expansion of those services along the outpatient continuum, because again, going back in to utilize the ASAM criteria and helping to identify, yes, there is a need and there are services that meet the need outside of that residential setting, versus creating that overwhelming need for everybody to be in residential or inpatient treatment. So allowing access, or just allowing the ability for people to access these services on an outpatient level, and just expanding that continuum to say, hey, here's where we are. We have increased these levels of care, and they are being utilized in support of, again, reducing the number of people who may or may not be appropriate for that inpatient or residential level, and able to get what they need on the community level.
Okay, thank you.
Does that make sense?
Okay, thank you, Ralph and Theresa. I'm going to bounce back and forth between the chat and live questions, so I'll come back to Preston in just one moment. We have a question from Marge Stone King in the chat. Do the services that have been covered by the waiver that have been discussed, do they require patients to meet the Medicaid income eligibility requirements?
I can take this one. The there are waivers for certain income eligibility requirements for children in the state of Alaska. I don't know about adults, but there are, if a child is out of the home in a facility, for instance, for 30 days, they can become eligible for Medicaid regardless of the income of the family that they came from. There are certain diagnoses which require medication or ongoing management of a medical condition that make a child eligible for something called the TEFRA option. And that was part of, I think it's called Tax Excise Financial Recovery Act, which was in the late 90s. And it gave sort of it's a type of income waiver for eligibility. But in most cases, the person must be eligible for Medicaid for these services to be billed to Medicaid. And now that being said, some of these services are or can be billed to other payers. But in this case, we're talking about Medicaid.
Right. And I'll just add, the agencies offer these services to people based on insurance. So if they have insurance, some agencies will, if they accept that insurance, they'll take them private pay as well and Medicaid. So nobody would be excluded from the services due to not having it.
Great, thank you. I'm going to add Preston Simmons in. Preston, you had a question?
Sure. Preston Simmons from Providence. First of all, thank you so much for an excellent presentation and very comprehensive set of services. So appreciate your leadership in expanding that for the state of Alaska. So what's in evaluation over the last few years under the 1115 waiver, what's still missing in our continuum, or areas that you believe that still need additional emphasis? Obviously, the one is crisis stabilization center isn't there, but really what else is missing that you feel would be most beneficial for the state?
I'm not sure what you're asking. Are you asking what should we add to the waiver, or what is in the waiver?
In essence, we have a broad range of the continuum services now that are very front end upstream to acute services. There are going to be areas that probably need additional emphasis or some additional investment. And what are those areas from your perspective now that you've been working in this for a while?
I can say though that due to the pandemic, just the timing of it, some of the service haven't had the ability to be stood up in some places. So that's one area or one spot of concern. And then there's feedback in rural areas that do need a lot more services than are available. And so in conversations that we've had, it's the thought process of, is there infrastructure available? Is there workforce available in those areas as well? So you have to consider all those things. And then just, we require the full continuum of step up and step down. So the services are on, but just getting them in the community, to be able to stand them up for all Alaskans. Because again, going back, I don't remember what it was, but the conversation we were having was, hey, we need this service, or we could use more recovery housing in this area. And when we took a look, we were going, is there even a place to have the recovery house? Because so again, the infrastructure, and then having that workforce, that everybody knows right now, we're struggling with having, licensed people or just the appropriately qualified people to provide the services all across the board. So that's an issue.
And I think also we all are in very close contact, particularly with our grantees. And one of the requirements, at least of children's grantees, is that they participate in what's called a community action plan. And the different communities have agencies who get together and meet regularly and talk about what's available in that community and what the gaps are. And we keep our fingers really close on that. And, as something kind of raises to the top, we bring it to back to the agency and to the powers that be and say, look, we're seeing this need. And I don't think that'll stop. I think that all of us hope to be very responsive to the needs of our communities.
And I also want to add, Preston, that in regards to crisis response services, we're really in some of that early development of some of those, like the crisis response facilities and implement that section of the 1115, well, a lot of the crisis response system and those 1115 services, being built and built up and developed in the system. And, we do have on our radar House Bill 172 and Senate Bill 124, which would create laws and regulations around crisis stabilization facilities. And so that is on our radar, and we're being mindful of that, and whether or not that is going to change, create some discussion around change in some of the 1115 services and how to create maybe a broader level of care, with the crisis stabilization facilities. Does that make sense?
It does. I was actually down in Juneau Monday and Tuesday, and that was one of the issues we were trying to promote. That's an important area.
Right. And so if those bills go through, we'll be taking, that's on our radar, and we need to take a look at how we're standing up those services and people opting in and opting out and what that would mean.
Well, thank you very much. Appreciate it.
Great, thanks, Preston. And all right, we have another question in chat. Theresa Bailey with Alaska Regional Hospital is online with us, and she's asking, are there thoughts about increasing sober living houses in Alaska? And I'll just add there, Anna Nelson's also in response, I think, to Preston's question, saying more affordable, safe housing would go a long way in helping people maintain their recovery. So any thoughts on that, Theresa, I guess?
Yes, I have many thoughts on increasing sober living housing. That is one of the areas that we're looking at, because we do understand that there's a significant need, and we're open to feedback, and we're researching more sober living options. I know that a lot of times we're looking at trying to take grant funding and see how we can best utilize it in communities that may need those services. So definitely, we acknowledge that need, we see that need, and we know 100% that more is needed. And again, it goes back to that question or that comment I made earlier, where we're looking at the areas in which we need it and how to stand it up, because do we even have the infrastructure? Do we have, people who could stand this service up in areas? I hope that kind of sort of answered.
Right, thank you. So it's definitely an area under consideration for any.
Absolutely.
I'm actually gonna step down to a process question from Dan Sadler, and I'll come back to another question that he had online in just a second. But so he's saying, is it safe to assume that the services that are authorized under the waiver would the waiver in and of just the name indicates sort of a temporary nature? So is there a schedule for renewal? Preston and Ralph have both talked about sort of the time frame and reporting on the outcomes of the waiver. So what is the longer term thinking with regard to it?
And this, I would like the expert to address this. I know Farina's on the line. If you can, Farina, step in and answer that question, that would be great.
Good morning.
Yeah.
Can everyone hear me?
Yes.
Good morning, and thank you for asking the question. Theresa and everyone knows I'm always excited to talk about the waiver, but we really want to allow our team to have an opportunity to really engage. But now that she's turned it over, yes, we are absolutely working on our 1115 waiver renewal. That application will be submitted, fingers crossed, December 2022, and that would give us a 2-year extension. The long-term expectation is that we will move several of the 1115 waiver services into our state plan as standard services that are available for all Alaskans. The waiver gives us an opportunity to really refine what worked. The key words that I like everyone to remember is that the 1115 is a demonstration. So over time, what we do is we engage and we work with our behavioral health providers that have stood up the services to identify what did we get right and what are some of those things that we need to refine, or what are measures or expectations and outcomes that we expected to see that just didn't work based on geography, workforce, or a myriad of other issues. But the long and the short is that we will onboard all of our 1115 services into our state plan.
All right, thank you so much, Farina. So I'm going to roll back up to Dan's earlier question now, which really is sort of what is the efficacy of the services that are being offered under the waiver? What kinds of indications do we have at this stage that that these are being effective in terms of addressing behavioral health needs in the state? And then an underlying aspect of it is there also some intention towards addressing prevention or the underlying causality of some of these behavioral health problems?
Absolutely. And so right now, I really need to give pause and thanks to the behavioral health providers for really leaning into our 1115 waiver. At the original onboarding of the 1115, the pandemic had not reared its head. And so the 1115 SUD component of the waiver rolled out. And what we saw were most of our providers onboarded, of course, the easier services to transition to, which were our residential levels of care, because many of them were already offering residential, but under a grant funded system. Through the 1115, they are able to shift to a different financial paradigm, which would be billing under Medicaid. And through the IMD waiver that we received through the 1115, they were allowed to expand capacity. Well, that you roll forward, that rolled out in July 2019. Regulations were made permanent in October. And then in March of that following year, the pandemic hit. And that really required providers to stop and really think about how do they continue to ensure that behavioral health services were being provided to vulnerable Alaskans in this new environment that we find ourselves continuing to deal with. At the same time, the division continued to work with the Center for Medicaid and Medicare Services to finalize the behavioral health component of the waiver. So when you ask where are we with outcomes, we are truly at this point just establishing our threshold measures, because we have to respect that Alaska is, and this is going to be a little bit weedsy, so I'll try to keep it as simple as possible, but we are a fee-for-service environment, which means it is dependent on our behavioral health providers to onboard the services. In a managed care environment, you have a capitated amount of money and you have a contracted list of providers, and you say, hey, these are the services we want you to provide. Here's the money that we're offering you to do so. This is not that environment. So when you overlay everything that happened with the pandemic, the impact of the pandemic on workforce and the escalating need of individuals in this behavioral health crisis that we're seeing, adding in a whole new set of services that comes with roughly 180 pages of regulation, I am mind blown, excited, and I cannot hide my appreciation for providers who have leaned in to stand up these services. So when you ask us about where we are in our metrics and our outcomes, we are at a threshold. We are just now establishing baseline, because we have to give respect to everything that's happened in Alaska and in the country and the world as a whole, but what it means for our providers when we say, okay, well, show me how individuals that you're serving are getting better. Show me those outcomes. We want to do this as a partnership and not come in heavy-handed with a bunch of bureaucratic red tape to say that you're not meeting the financial expectations and the outcomes that we expected to see 2 years in, when many of our providers have maybe onboarded the service for 9 months.
Okay, thank you for that, Farina. A quick question, and maybe a simple one, with regard to opioid treatment. What's the trend line with regard to case counts now? Are we seeing any impact of services? Do we know any initial data on are caseloads continuing to increase? Are they moderating, or what else are you seeing?
So the answer is yes. Are we seeing, for opioid treatment services, are we seeing an increase in the number of people utilizing services? Is that what you're asking?
Yes.
Okay, yes, absolutely. And this is actually my opportunity to throw in a plug for an OTP that we have 6 OTPs across the state right now. We had 5, and we had so we have 1 in Fairbanks, 3 in Anchorage, 1 in Wasilla, and we had 1 open up in Juneau. And so they actually tripled admissions in the span of a month. And it was just the service we knew was needed in that area, but we didn't know to what extent. So we have providers, buprenorphine prescribers, on the slide where I talked about these data waiver providers and the number of people who are accessing treatment through them. Number of people who are receiving outpatient treatment and their primary diagnosis is an opioid, is significant across the state. So the need is there to find treatment and to have access available for patients. And, people who have heard me in other presentations, where I say we need to have methadone, buprenorphine, we need to have all these services available for people because we don't know what's best. There is no one size fits all treatment for people, but we need to be able to have the service available so that people can use it, because we know that there is the number of overdoses is staggering. And so it's important that when a person is in need of treatment, that they should be able to access it immediately, because we don't get the luxury of believing or knowing that they'll be safe until next week when they can enter treatment somewhere. So I think outpatient providers are across the board are experiencing these increases. They're seeing this. They have a finger on the pulse of what's going on. A lot of people are taking advantage of Project Hope and other providers that are giving them Narcan so they can make it available for patients and non-patients, just people in the community who need that, because even if you're not ready for treatment, there's that need to make sure that people are safe and that they have access to something that will give them the ability to be safe.
Well, thank you, Theresa. Well, we're coming up on 9:15. I do have one final question for you all. And I'm going to bring Farina in on this discussion as well. Let me add her in. There you go. One final question for you all. This was addressed a little bit earlier, I believe, with Ralph's question. But if there was one policy area where you're continuing to see gaps or simply some barrier or hurdle that would, if removed, that would improve outcomes or ease delivery of services. Could you each speak to that? What area would you like to see some additional policy improvements and or knocking down of hurdles? We can just start with Theresa.
Knocking down of hurdles. There have been a couple of things happening due to the pandemic, some flexibilities that have happened with regard to access to, pharmacotherapy access is something I spoke to earlier, with just allowing people to access, medication for addiction treatment easier. And so I think that's a good direction that we're going in, because what we don't want is a lot of policies that stand in the way as barriers. A lot of providers not being able to get all the trainings that are required, or whatever that thing may be that would hinder access to pharmacotherapy. So I say any policy that's going to allow us to address those barriers and allow access for those people who need it, I am 100% in 1,000% in favor of.
Great, thank you, Theresa. Tina?
I'm not really thinking policy. I'm not quite sure, but I'm thinking workforce development is really a huge issue for our providers, and in terms of providing services and actually policy, now that I'm thinking about it, and workforce development and kind of where we are, I'm thinking policy around expanding broadband access in Alaska to those rural areas. That would help with even workforce issues and service provision and a lot of areas.
Are there licensure issues with folks who maybe are licensed in other jurisdictions and are not
There,
working?
as what's happening in the lower 48 as well, licensing issues is an issue, and reciprocity among different states and making licensing go faster, that process. And so, yeah, licensing is an issue as well.
All right, great. Thanks, Tina. How about you, Bunty?
Well, it's interesting. One of the things that Farina said that has been a huge barrier, well, two huge barriers actually, into the implementation of the children's services. One was, of course, the pandemic. And the big deal is that our prevention services were to take place in the home and in the community. And when the pandemic hit, people don't want to go into the homes. You know, they don't want to go out into the community. We were all pretty much, hunkered down and masked up. And so a lot of those things didn't happen. And then to add insult to injury, we had a cyber attack at the state level. And so when you talk about licensing, it was the Department of Health and Social Services. And so it affected licensing. It affected everything we did pretty much. And it affected even how we implemented. Did the service authorization policies get implemented? So kind of in my way of thinking is our jury's still out. We still haven't been able to look at what's working in some of the most exciting parts of the waiver where children are concerned. And that are those prevention services.
Great. All right. Thank you. Thank you, Bunty. And Farina, thanks for joining us also this morning. Any thoughts from you on this topic?
Sure. What we are actively looking at is the administrative burden that impacts access. We truly understand that in order to create significant and longstanding change, we have to have low barrier to no barrier access to care. And that's hard to do when we are talking about Medicaid, because Medicaid tends to be inflexible and CMS, they like their rules. And so finding that balance between ensuring that we are creating pathways to allow providers to create low barrier, no barrier access while adhering to our requirements on a federal level is a little trickier than most people might think, but that is what our one of our many focuses, but definitely a primary focus. So that would be what I would offer.
Great. Thank you so much. Well, thank you all. Just a reminder before I turn it back to Ralph that we have our next session on April 28th on the Crisis Now model, and representatives with the Alaska Mental Health Trust will be with us that morning, along with several of their partner agencies. I'm posting in chat now the link to register for that session, so I encourage you all to attend. And with that, let me ask Ralph to come back in with any final thoughts or closing remarks.
Well, I just very much want to thank our participants today, and actually thank Farina for joining us as well. Appreciated the broader agency perspective, as well as the perspective of the three programs that are represented by Tina and Bunti and Theresa. And I think what I would like to close with is that the study group that we're working on is looking at the issue of chronic disease management as the focus for our programs this spring. And I'm really pleased that we've been able to reach out to both disparate or some distinct programs like the HUMS program in the program a couple weeks ago, but notice that one of the programs that was referenced in today's programs was the Crisis Now program that we'll be talking about in 2 weeks. So I hope that Commonwealth North is really providing an opportunity for people who are interested in this important and challenging area for service delivery in healthcare, what Alaska is trying to do and how what Alaska is doing is connected to the broader thinking in the medical community about managing these complex medical problems that present a significant challenge, both in terms of the quality of services that we're able to deliver and also the cost of delivering those in our large and complex medical system. So very much appreciate the contributors today and look forward to being able for Commonwealth North to be able to continue to provide some information to people who are interested in this important area.
All right, thanks.